cancer survivors.
Thank you. I'm really thrilled to be here to focus us on cancer survivors and also on why we need to be considering prevention for cancer survivors, something I'm very passionate about. So thanks to early detection, better treatments, and the efforts of probably many of you in this room, or all of you in this room, the number of cancer survivors in the United States has grown exponentially over the years. And we have about 14 million in the United States today. We project that number by 2022 is going to be up around 18 million. And more to the point, you can see the growth in the blue bars at the top, which is the number of people who are living 15 plus years after cancer. So take home message, there's a lot of people living a lot of years after cancer. And cancer survivors are still they're an at-risk group. They're still in need of prevention. Just because you have cancer doesn't mean that you don't need to focus on prevention anymore. They're at risk of chronic effects of cancer. So chronic effects of cancer are present when you're undergoing chemotherapy, radiation, and then they continue for months, sometimes even years, or sometimes as long as we can measure it after cancer. These are things like depression, anxiety, fatigue is a big one, pain, neuropathy, lymphedema. The financial burden we've heard about already today is enormous. The bankruptcy rate and this has enormous implications for people's ability to be active in their care and to make full potential of all of the wonderful recommendations that we have for their aftercare. Cancer survivors are also at risk of late effects of cancer. These are things that are not present during chemotherapy, primary treatment, but they pop up seemingly out of nowhere, months, even sometimes years after cancer is over, after cancer treatment is over. These are problems like cardiovascular disease, of course recurrence, new cancers, diabetes, bone loss, and osteoporosis. What I'm particularly concerned about in terms of rehabilitation needs is this accumulation of comorbidities that spirals them into disability. We borrowed this slide from Kevin Effinger in the National Child Cohort Study. We have a wonderful opportunity to study people who were treated for cancer as children. And 30 years later, 73% of them had at least one chronic health condition. 42% had a grade 3 to 5, which is a severe life-threatening condition or even death. And in the childhood cancer, the cohort study, we've got the opportunity to compare them to their siblings. And survivors were over 8 times as likely to have a severe or life-threatening problem compared to their siblings. So this is significant. In adults, we see the same kind of problem. The green bars are cancer survivors compared to the general population, and you see survivors are much more likely to have problems with functional limitations, activities of daily living impairments, psychological problems, and work, which again has more financial implications. And the number of comorbid conditions, as Rachel pointed out, is much higher in cancer survivors. They're much more likely to have a greater comorbidity burden. Add to all of this the fact that for many, because of all of the wonderful work that we're all doing with cancer treatment, for many cancer survivors, they are not going to die of their cancer. They're going to die of competing causes, all of these comorbidities that we're talking about. For example, older breast cancer survivors who have early stage disease are much more likely to die of cardiovascular disease. With prostate cancer survivors, the 15-year mortality rates are 30% from non-prostate cancer sources and only 5% from prostate cancer. And with young men who have had testicular cancer, these are men under the age of 35 who are treated with radiation therapy, they're almost twice as likely to die of circulatory disease than the general population. So 2 points here. Cancer survivors, many of them much more likely to die of competing causes than cancer, and they're more likely to die of these competing causes than the general population. So the comorbidities are extensively a problem. Now, let's throw a wrench in it and talk about the fact that the baby boomers are aging, and a lot of them are going to start getting cancer and have already started. So we predict there's going to be an enormous growth in the number of cancer survivors in a decade here, but that growth is mainly in people over the age of 65. So there's going to be a 47% increase in a decade in the number of cancer survivors who are over the age of 65. This has huge implications for policy and for clinical care because these people come with comorbidities already. They also come with a set of expectations about what we're going to be able to return them to. So the picture on the left, I like to say, is about when my grandmother had breast cancer twice, what her physicians thought was a decent quality of life that they could return her to. Now, this didn't work for her because she had a farm to run, but now expectations of the baby boomers are quite different. These are people who are out climbing rock walls and doing who knows what, and they expect to be returned to what you see on the right, which is a gentleman probably in his 80s who, if you can't tell, is water skiing barefoot. So that's their standard. That's where we have to return them to. So what we need is a new model of survivorship care that really focuses on creating well survivors. It has to work with this increasing number of survivors that are living years and years and years after cancer, especially the ones who are older adults. They need prevention or control of their multiple comorbidities. They need rehabilitation to prevent or control the chronic effects of treatment, and also to decrease the risk for these late effects, the cardiovascular toxicities, for example. And basically, the system of care has to be focused on preventing that spiral into disability. So I know a lot of people in the audience, of course many of them have left, really want druggable targets, but I will offer that I think we're going to get a lot more bang for our buck with promoting healthy behaviors, like Rachel was just talking about with the general population. So how are we doing with cancer survivors and health behaviors? Well, our most recent MMWR report says about 15% of them smoke. But that's not really the whole story, because when you break it out by age, you can see that it's the young people who are smoking in much greater rates than their peers. The bars on the left are cancer survivors versus the general population, ages 18 to 44. That's where you see the tremendous opportunity for smoking cessation and the great need. Sedentary behavior, like we've all been engaging in all day, yep, about a little under a third of the population of cancer survivors. And if you look at the middle bars here, meeting physical activity guidelines, you can see that that changes with age and decreases with age as well. So again, we need to focus on our older adults especially. Obesity, about 27%, so about on par with the general population. Okay, so if I'm up here saying health behaviors are so important, are physicians talking to healthcare providers about their health behaviors? Are physicians talking with cancer survivors, about their health behaviors? Well, we've got a nice study that shows that compared to adults without cancer, cancer survivors are a teeny tiny bit more likely to have these discussions with their doctors about diet and about exercise. But look at those rates. That's 30% of cancer survivors having a discussion about what they're eating. 26% having a discussion about exercise. There is enormous room for improvement here. I'd give everybody an F. And definitely on smoking cessation as well. So to conclude, you asked for the top 3 policy issues that the forum might address. I cheated and gave you one. It's in my mind, it's really all about promoting exercise, healthy eating, weight control, and smoking cessation, and that's where bang for our buck is going to be. But what I did is give you 3 different specifics that we have to address to get there, because I'm not the first person to say this. A lot of people have said this, but we're not doing it. So what do we really have to attack from policy standpoints to get there? So here are the 3 specifics. Who should deliver the intervention? Should it be oncologists? They're telling me, forget it, Catherine. I've got busy clinics. I need to outsource this. Okay, PCPs, well, they can reimburse for it, but they don't have time and they're not trained. Third parties, people like me who are trained to do this, we're not reimbursed. So who does this? What interventions should be delivered? Should they be the same interventions that the general population gets that Rachel was talking about? Should they be specific to cancer survivors? Is there something special about being a cancer survivor and needing to lose weight or needing to exercise? We don't know. When should this happen? Should this happen as a teachable moment during chemotherapy, after chemotherapy? How should these be delivered? Who should pay for this? How do we promote maintenance of these lifestyle changes? And really, how do we promote change in families? Because if we don't look at BMI running in families, exercise running in families, smoking running in families, we're never going to get maintenance of changes that's really meaningful unless we look at this as a family issue. I'll stop there. Thank you.
Thank you, Catherine. Our next speaker is Jeffrey Levy, and he is the Executive Director for the Trust for America's Health, which is a health advocacy organization to prevent disease, protect health and safety of communities.